Request Dr. Natarajan sir and Dr. Danamitran sir to chair the next session, please. Over to you, sir.
We welcome you post-lunch for the session 4. The first talk is going to be, can I have the slide of the introduction slide? The first talk is on stem cell therapy in diabetes, what is new. For that, we have eminent speaker, Dr. Gauri Shankar, who would do justice for any topic, and this is going to do a great one. Can I have the introduction slide? Over to Dr. Gauri.
Thank you, sir. Thanks for the introduction, sir. Yeah. Over the next 15 minutes, I will be talking to you about stem cells and diabetes. The topic is stem cells in diabetes, the recent trends. Okay. So, I will briefly take you to a patient. We will call her Catherine. So one day, it was a busy practice, like I was sitting in the hospital at around 1:30 or so. I was talking to her. She was conversating with me. She's a type 1 diabetic patient, type 1 diabetic for the past 20 years. And while she was conversating with me, it was post-lunch, she was giving a very starry look. I was just stunned, like, why is she looking at me at a starry look in the midst of conversation? So I was not knowing what is happening to her. I asked her, like, are you all right? She was kept staring at me. Can you just, do you have any clue what was happening there? She was just, she's a type 1, giving a starry look, not responding what I'm asking, but she was not sweating. She didn't have any other things. When I asked her to raise her hand, she was doing, but she was looking confused. So what was happening? So she was wearing a CGMS. Her CGMS didn't give her any clue that she is going for a hypoglycemia, like what Mohan sir said. But what was happening to her was, it was a hypoglycemia unawareness. So the patient is conscious, but she is awake, she's bit oriented, but confused. She's sitting in the midst of the presentation and she was getting confused. So this brings to this entity called as hypoglycemia unawareness, where imagine like she's driving the vehicle or she's in the midst of a surgery or in the class or something like that, what would have happened to her or for the other people around her? She's sitting there, she's obeying commands, but she's not knowing what is happening to her at all. So we need to understand this hypoglycemia unawareness is an prelude to the overt hypoglycemia. We may always say like we can use continuous glucose monitoring in our patients to address this. So because continuous glucose monitoring can make the patient aware that she is wearing the device and that is going to show the reading. But do continuous glucose monitors really address this problem? This is one study where they did among people with hypoglycemia unawareness, going for overt hypoglycemia. So you need to understand, people are having hypoglycemia unawareness, but they are going for overt hypoglycemia. Does CGMS prevent this episode or not? What was shown in this study was, it doesn't prevent at all. So that is something which we need to fundamentally know. So the second thing is, this is a closed loop insulin pump which was used in young kids of the age 6 years or so, where when we mean by closed loop, the patients are wearing a insulin pump and they are having a CGMS also, but at the same time, both are so interrelated that you don't need to give any basal insulin for them, but for prandial insulin, that is why it is called as hybrid closed loop. Means for prandial sugars also, the kid may be eating, the kid may not be eating, may be overeating and all these things to see whether the what is the glycemic content that they have consumed. They have made it into a closed loop system, and when these people are put into this sort of insulin pump, they are not able to prevent any of these complications. So whether the patient goes for number of severe adverse events or severe hypoglycemia, or in fact even people going for diabetic ketoacidosis, people who are on pump are having more amount of event than people who are on basal bolus therapy. So we always understand, like when we treat type 1 diabetic patients, devices like this, CGMS or the insulin pump should address their problem, but it is not addressing. So what next? We can do pancreatic transplant. Pancreatic transplant has been addressed very much in patients, especially in the Caucasian countries and all. So where they had an exposure to renal transplant, pancreatic transplant was done simultaneously. So simultaneous kidney pancreatic transplant was done, but that also didn't show any much effect. Then they try to look at, can we do islet transplantation? So you fetch islet from the cadaver of the patients And this islets are, you have to take at least from 2-3 patients, you have to take the islet, because one pancreas is not sufficient to give them adequate islet for a patient. So you have to take it at least from 2-3 patients. So you end up taking the pancreas or islets of 2-3 patients where it is put into the portal vein and see whether these islets are able to grafted and whether they can secrete the insulin. So this was also attempted. This was also fairly, it was not showing successful since 2010 because the incidence of islet transplantation is drastically coming down, and since it is being taken from 2-3 people, it also has, you have to be put on much of immunotherapies. So this problem is always there, not fairly successful. So now we need to understand like all this technology, whatever we are discussing, it is very difficult. So like what we are talking, it is much more drier. So the first point that we need to know after these things is CGMS is not helping our type 1 diabetic patients. The closed loop are always are not helping them. Neither the islet transplant is not helping them, which we need to think much more ahead. That is the first point. Now what should we do? We have something called as stem cell therapy. That is the topic that we are discussing. What are these stem cells are? Stem cells have the unique capacity that they can go for self-renewal. Means they can multiply into n numbers. So the cells can multiply without changing its lineage. They can multiply. That is one point. Second thing, the potency of the cell is maintained. So if you give it as red blood cells, what you get? You get only red blood cells. So potency is maintained. They can multiply. So these are the two principal properties that we need to know about stem cells. So let us say like a simple stem cell transplant that most of us would have got exposed to in some of our patients, the bone marrow transplant. So in bone marrow transplant, typically what happens, as you see in the bone is infested with malignant cells. So half the bone is getting destroyed as it is shown over here. You have the malignant cells are there and you have given a chemotherapy. So the normal cells also have been destroyed. So the malignant cells are destroyed, the normal cells also destroyed. In these people, when you do a chemotherapy for these patients, you infest or after the chemotherapy, when you give a hematopoietic stem cells, let us call it as just stem cells. So when you give a stem cells to these patients, what happens? The new cell starts multiplying and the patients are having the required lineage. So it could be red blood cells, it could be white blood cells, or it could be the platelets. So whatever we need, the stem cells are able to multiply to whatever it is required. So that is how the bone marrow transplant is being done. So how do these hematopoietic stem cells know whether to make to know? There are two things that happens. One is there are something called as epigenetic marks. So what does this, and there is another thing called as transcription factor. The transcription factors, something like GATA1, or there are many transcription factors which are infested into these cells. These cells make the genes to produce the particular lineage what is required, and also at the same time, the epigenetic marks makes it on and off. So if red blood cells are required, it will produce only red blood cells. If adipocytes are required, it will produce only adipocytes. If muscle cells are required, it will produce only muscle cells. So the transcription factors and the epigenetic factors control that. Second thing is, what is the environment that is present over there? If erythropoietin is present over there, it produces RBCs. If colony stimulating factors are there, it will produce only WBCs. So there are three things that come over. One is the epigenetic marks. The other is the transcription factor which comes in. The third is what is the epigenetic? What is the environment, microenvironment which is present there. So if it is infested into the bone marrow, it will produce RBCs or WBCs or platelets which is required. So this is what it does. So this is what we call it as the pluripotent cells. So you have the markers, you have the red blood cells which are earlier present, where we can ask somebody to donate, and these cells are made to give the same lineage, RBCs or WBCs. But what will happen, say, suppose if I want to do a stem cell therapy for Parkinson's, or if I want to do a stem cell therapy for heart failure, these are all much approved things. So if I want to do that, we won't have heart cells. You can't take it from the patients, and because the RBCs which are donated are from donors. But who will donate a live liver or a live, say, brain or heart? So there is a problem. So you cannot fetch all these things. So that is where the problem is. Now we have to understand there are two things. One is the pluripotent cells and the second is multipotent cells. The blood cells that I was talking is all about the multipotent cells. So multipotent cells can get divided into only those cell types, whereas the pluripotent cells are the originator cells where it can be taken from the embryo, and these cells can get divided into any type. It can get divided into muscles, it can divided into brain cells, it can divided into heart cells, it can divided into adipocytes. So whatever is required, it will get transformed. So two things that we need to know. It is something like multipotent is about a cardiologist who wants to excel. He can excel only with electrophysiology, or he can excel with heart failure. But whereas in the pluripotent cells, it is like an intern, or it is like an MBBS graduate. He can do cardiology, nephrology, neurology. So pluripotent cells have got adequate capacity to get differentiated into all other cells that is required. So if at all, if we want to regenerate the beta cells, what should we use? We should use the pluripotent cells. Now that you have understood between pluripotent and the multipotent cells, the problem with the pluripotent cells is, where does this pluripotent cells comes from? Pluripotent cells, after fertilization, you have the zygote. So once the zygote is available, this zygote, it gets, on the 5th day, it gets converted to a blastocyst. In the blastocyst, the outer layer is called as the trophoblast. This trophoblast gets differentiated into your placenta. The innermost cell membrane is the one where we fetch, and this is what becomes a pluripotent stem cells. So pluripotent stem cells comes from the embryo. Now, if you want to have the pluripotent cells for human beings, who will give an embryo on the 5th day? So there are lots of ethical reasons comes in. So it is difficult to fetch all these cells. Also, the problem will be, when we give this pluripotent cells, what happens? These cells, as I said, it can get multiplied into any cells. It can get multiplied to RBCs, WBCs, all these things. It can get multiplied to heart cells. It can get differentiated to adipocytes, all these things. So there can be an uncontrolled differentiation can happen. Also, since they are coming from the inner cell membrane, they can get converted to ectoderm, endoderm, mesoderm, like how it forms in the teratoma. All the cells can get developed. So we have the chances of becoming teratoma also. And as I said, ethical issues are there. Who will give an embryo on the 5th day? So nobody is willing to give. And immunological reactions also can happen when we give that. So for that to address, we have something called as induced pluripotent cells, where what they do is, these induced pluripotent cells are fetched from the keratocytes. So are any other cells, as shown over here from the skin cells, then they de-differentiate it. I said the stem cells gets differentiated. You get cells from the keratocytes or from any cells, and then they de-differentiate it and re-differentiate it, which is called as induced pluripotent cells. So these induced pluripotent cells will become like the cells which doesn't have all the side effects. So that is the advantage of induced pluripotent cells. So the problem, whatever which we see with the embryonic stem cells or the pluripotent cells, are not there with induced pluripotent cells. So now remember only one thing. You have multipotent cells. Multipotent cells can get differentiated into whatever you want, RBCs, WBCs, or platelets. You have pluripotent cells. Pluripotent cells can get differentiated into any form, but there are risks of other things. As I said, embryo, and it is difficult to get. So what is the solution we have? We have the induced pluripotent cells. The induced pluripotent cells doesn't have all these problems. Now comes the technology. So engineering islets from stem cells. So we have something, this is what I want to talk. I will just take exactly 3 minutes. So stem cell derived fully differentiated islets for type 1 diabetes. So all that we have discussed, you can get this from keratocytes also, or you can, like you know about 1996, how Dolly get engineered and all. So from a single cell, they were able to clone a big sheep. So something like that, they are able to clone the islet cells, and from there, they are able to derive this pluripotent cells. So they are also induced pluripotent cells. These induced pluripotent cells doesn't generate only beta cells, they generate islets. So what do these islet cells? They can produce, they will have beta cells, they will have alpha cells, they will have somatostatin, all these components will be there. So not only they produce insulin, they will also produce glucagon also, whereby if the patients go for hypoglycemia, that will be addressed. Sorry, I will take just 2 minutes. So insulin also, insulin gets produced, as well as glucagon also gets produced. So that is the advantage of this. So this is called as Zim-Eiley cell. Zim, Z-I-M, Eiley cell. That is how you need to you need to pronounce it. So Zim-Eiley cell, they are able to take this cells into the portal vein and able to engraft in the liver. So when it is done, like they are able to produce insulin. So that is how it works. Now it is available, it has come, the phase 1 and phase 2 studies have done. What they have done in this phase 1 and phase 2 study is, First, they have taken only 2 subjects. Exactly, this article got published exactly 1 month back, even 25 days back in NEJM. So what they have done, phase 1 study was with human beings. 2 subjects they have taken, and Zim-Ilicel was given into the portal vein and placed in the liver in half the dose. Then once it was successful, the patients didn't have any reaction. Then they took another 2 more subjects, and instead of giving half dose, they gave full dose and saw for 1 month in the 3rd patient, for another 1 month in the 4th patient. Once they were able to do this, then for next 8 patients, they were able to give at the same time. For other 8 patients, they gave in the same time. So in part A, when they said first studied in 2 patients, what they looked at was, they looked at the safety when you give, because all the time, if I would have been given this talk 1 month back, I will be speaking only on animal experiments. But here we have the human data, where when Zim-Ilicel was given, the first 2 patients, the safety was proven. The patients didn't have any side effect. In the next 2 patients, the full dose was given, there was no side effect. And the next 8 patients, they give concurrently and were following up for more than 1 year. So what they were trying to do is, the primary endpoint was what was the C-peptide which was present in these patients. So that shows how much amount of insulin that gets secreted from the pancreas. So the primary endpoint was detectable C-peptide, how much it was present. Because if C-peptide is good, it means insulin is getting secreted in a good quality. So when they saw the primary endpoint, it was showing, I will come to the results, that was the primary endpoint. The secondary endpoint was, they saw whether the HbA1c is improved. They were all put on CGMS, whether the target in range was achieved, whether there is a decrease in the hypoglycemia. That is the fundamental thing that we want in our patients. Because type 1 diabetic patients, as we saw in the first slide, we were talking about Catherine. So what was the problem with her? Though you put a basal bolus, though you put CGMS, what was happening? You are not able to prevent hypoglycemia at all. So in the inclusion trial, they included patients who had at least 2 episodes of hypoglycemia, and they are at least diabetic for past 5 years, and no detectable C-peptide in these patients. So when they saw in these patients, there was no, in the follow-up study for 2 years, there was not even a single episode of hypoglycemia, and whether the patients were becoming insulin independent. That is what is important, no? When you give a stem cell therapy. So when the study was done, the total insulin dose, as you see over here, just follow the dark black line over here. So that was showing the total daily insulin dose requirement was about 60 to 80% in those patients. So the insulin requirement was drastically falling. Not only the insulin requirement, see the HbA1c, it was all falling between 5 and 6. The patients didn't require insulin at all. The C-peptide level was very good. So this showed that these stem cell therapy, which has been done for these 12 patients, is a promising area in the field of type 1 diabetes. So stem cells are the future in type 1 diabetes, and the carry home point should be, I said, in type 1 patients, we have like the management is very challenging. Hypoglycemia, unawareness and hypoglycemia, we are not able to address. Stem cells offer hope, but the hope is very bright. Now it has moved from animal studies to human studies. So it is something which we need to actively look for. With this, I would like to thank you for giving me this opportunity. Thank you.
Thank you, Dr. Gauri Shankar, for an excellent presentation. Okay,
if there are any quick 1 or 2 questions, I will take it. Madam, this has been done by pharmaceuticals by name Vertex Pharma, madam. They not in Chennai. They are all US, so that is where they have done. Probably we can look for in future when they do this. Only phase 2 trial has been done. Phase 3 it is being converted to. So phase 3 reports we have not received. Phase 1 and phase 2 data we have shown. Madam, Zim-Ilicel, that's what, madam, I showed, no, like it has induced pluripotentic stem cells, which are placed in the portal, they are placed in the liver. They are not placing it in the pancreas. So you need to understand, because when you try to place it in the pancreas, pancreas will get, is more vulnerable for damage, and the cells can get destroyed, all these things there, because that part of it they derived from when they placed islet cells. So when islet cell was getting transplanted, they placed it in the liver. So they took the clue from there and placed the Zim-Ilicel also through the portal, because administering it through the portal vein is also easier than placing it directly through an injection into the pancreas. So that is where they are placing. They place it in the liver.
I think Indian laws don't allow
Islet cell transplant, pancreatic transplant, there are few centers in Chennai they were trying to do, but I don't know anybody has done, but I know one pancreatic transplant surgeon, but islet cell, I don't know whether they are doing anywhere. But this is a promising thing which we need to look for. It is going to change the landscape. So really it is something which is good, and all the patients are doing good till whatever data has been published. In India, there is no center. Madam, that study name is called as Forward Study, madam. It was published NEJM last month, 20th. This is September, no? It was published on July 20th, madam. Forward Study. You can just Google as Zim Islet cell, madam. You will get it, madam.
So thank you, Dr. Gauri Shankar, for leaving us with a promise of the future stem cell therapy in type 1 diabetes. Thank you again. Now we move on to the next session. I invite Dr. Balaji Chidambaram to speak on gut, adipose, and brain metabolic communication. The introduction slide, please. Okay, yeah. So Dr. Balaji Chidambaram is the founder secretary, Metabolic Club, Kumbakonam. He does a lot of activities and is a very dynamic diabetologist. It's a short introduction. I think I will hand over the session to Dr. Balaji.
Sure, sir. Thank you, sir. So thanks to the chairpersons for the nice introduction. So at the outset, my sincere thanks to Dr. Shanmugam sir and the entire DAISICON team for making me part of this DAISICON 2025. So it's very difficult to speak after a dynamic talk by Gauri for any speaker. So my topic is gut, adipose and brain metabolic communication, the triad of energy homeostasis. So the metabolic symphony, so why the communication matters. So the brain, gut and adipose tissue have an integrated network in maintain the energy balance. So this sophisticated communication system, so it operates continuously and it coordinates the metabolic processes to keep our body always function systematically. So when there has been disruptions in this communications, they underlie the obesity, diabetes and other metabolic diseases. So understanding this triad is the key to innovative therapies and lifestyle interventions that could just revolutionize the metabolic health care. So we all know the global metabolic challenge what we face today. So the incidence of obesity, type 2 diabetes and associated cardiovascular diseases has grown to pandemic proportions, showing no signs of reversing. So these conditions significantly reduce the lifespan and quality. So despite various education measures and new therapeutic options has come into the things. So a major contributing factor is the obesogenic environment with easy access to energy-rich foods leading to overeating and energy surplus. So current interventions often just face challenges as the body weight is frequently regained in the long term. So the genetic heritage meets the modern lifestyle. So what is the genetic susceptibility? So if we just see the individual variations in the metabolic efficiency and the energy storage capacity which has been inherited from extraordinary adaptations. So if you just see the environmental influences on the other side, so modern lifestyle factors that interact with the genetic predisposition to intervene the metabolic instance. So body weight and metabolic health result from complex interactions between genetic susceptibility and the environmental influences. So the gene environment, so they interplay. So this determines individual responses to the dietary interventions and susceptibility to the metabolic dysfunction. So what are the contribution of genetic heritage and modern lifestyle to body weight? If you just see, there has been a diet, lifestyle, all aging, circadian rhythm, epigenetics, genetics and smoking, they all come in a line. So these genetic environmental interactions in the body weight control, if you just see this comprehensive diagram illustrates the multifactorial nature of body weight regulation, demonstrating how the genetic predisposition interacts with the environmental factors. So the comprehensive diagram just it illustrates the multifactorial nature of body weight regulation, demonstrating the genetic predisposition interacts with the environmental factors. So this visualization emphasizes that no single factor regulates in its revolution, because dietary patterns, physical activity levels, sleep quality, stress management, and all the lifestyle things, they work synergistically to influence the metabolic health. So with this background, we know that brain, the master regulator of energy and homeostasis. So what about the hypothalamus control centers? So the arcuate nucleus and the ventromedial hypothalamus, they sense the hormones from the gut and adipose tissue. So they integrate the various metabolic signals to regulate the appetite and the energy balances. Secondly, the brainstem processing. So the nucleus tractus solitarius, and the dorsal motor nucleus, they receive the signals from via the vagal efferents and they process the various aspects. So lastly, the leptin resistance, we all know about the thing. The central leptin resistance in the hypothalamus has become a major driver of obesity, providing proper energy balance regulation despite adequate fat stores and other things. So the brain control of energy homeostasis. So first is the metabolic monitoring, second the signal integration, third the response coordination, and lastly the homeostatic adjustment. So this human body, they maintains the energy homeostasis through a intricately balanced systems operating at multiple physiological levels. So first about the forebrain metabolic sensing centers. So the arcuate nucleus and the ventromedial hypothalamus and the paraventricular nucleus, they all play an integral role, and the hypothalamus represents the most important mediated metabolic sensing agent in the forebrain, which contains various nucleus and is being responsible for various aspects of energy homeostasis. Secondly, the hindbrain metabolic process centers. So three important things happens. First, signal reduction. Second, the signal integration. Third, it's the information relay. So these three plays an important role. So this gut-brain communication networks through the various gut hormones and the afferent neurons, they represent the key signaling pathways in the gut-brain communication that fundamentally they regulate the energy metabolism. So this complex network strategies multiple layers of information to control the various behavior and metabolic responses. So next, it's the adipose tissue, where the energy is being stored, and it's an endocrine organ, starting from the energy storage to endocrine signaling and finally the metabolic regulation. So these adipose tissue functions in both the body's primary energy storage deposit and a sophisticated endocrine organ. So the white adipose tissue stores the energy efficiently, and whereas the brown adipose tissue, they specializes only in thermogenesis and the energy expenditure. So visualizing the triad of the communication pathways at a glance. If you just see the gut-brain hormonal communication pathways. First, the hormone secretion. So second, the blood-brain transport. Thirdly, the neural processing. And lastly, the system integration. So these are the four important things in a gut-brain hormonal communication pathways. So this diagram, it shows the inter-organ metabolic coordination. If you just see a overview of the various inter-organ coordination of metabolism in a normal metabolically healthy individual and in a compromised individual, what compromises has been done in the various aspect of intercommunication coordination. So the peripheral nervous system, what happens in the metabolic control? So the peripheral nervous system, it functions an integral component in the neuroendocrine regulation, providing a rapid connection between the brain and the metabolic organs. So these sensory neurons, the descending autonomic nervous system, and through the multiple various signals, they play an important role in the things. Lastly, the environment determinants of metabolic health. If you just see the built environment, access to various changes in our lifestyle, Secondly, the food environment, and lastly, the socio-economic factors. So these environmental factors, they play an important role in influencing the metabolic health concerns. So the circadian coordination of the metabolic processes. So the temporal coordination of the metabolism between various organs, they depend on a sophisticated circadian timing system that synchronizes various cellular tissue and systemic functions, and they operate during the light and the dark cycles. So this genetic molecular clock, they comprises various activating BMAL1 and the clock along with the various PVR and COR1 genes and the things which act in coordination, and they are responsible with the things. So this is the gut-brain pathways and the neural signals which acts to the vagal efferents. If you just see, once the nutrient is digested and absorbed, it's been secreted out in the satiety signals, through the satiety signals. Thereby, it stimulates the vagal sensory nerves, and which is responsible for the NTS stimulating of the hindbrain centers and the receptors for the gut hormones and the peptides. And these are responsible finally for the inhibition of the hepatic glucose production. So this is about the vagal afferent neural signaling pathways which I told you before. And the second thing is the adipose tissue communication with the brain. So three important aspects happens in the adipose tissue. One is the neural inputs, secondly the central sensing, and lastly the leptin regulation. So these three plays an important role in the adipose tissue communication with the brain. So these are the brain gut outputs, what happens in the autonomic and the neuroendocrine thing. So first the PVH projections which are responsible, and the neurons projecting to the lower autonomic centers. Next, the neuroendocrine output. So the feedback from the gut hormones influences the neuroendocrine output. And third, the central glucose sensing, which affects the liver lipoprotein secretion. And lastly, the parasympathetic outflow, where the central insulin affects on the hepatic glucose production. So the central control of the various peripheral metabolism. So these are the things: the central glucose sensing, the gut hormone feedback, and the central insulin effects. So the gut microbiota, gut-brain axis, so it acts on four important things. Firstly, the microbial metabolism, in which the intestinal bacteria, it produces the various metabolites, including the short-chain fatty acids and the neurotransmitters. Second, the gut-to-brain signaling. Third, brain to gut regulation, where which the autonomic nervous system regulates the gut motility and the microbial composition through stress and the dietary responses. And lastly, the central integration, in which the brain processes microbiome derived signals. They influence the mood, metabolism, and their feeding behavior. So this circadian clock control of the metabolic organs. First, the central pacemaker, the suprachiasmatic nucleus, which serves as a master clock coordinating the peripheral organ rhythms through the neural hormonal signals. Secondly, the liver clock. So the hepatic BMAL1, which controls the glycogen metabolism and the glucose production, and liver specific knockout causes the systematic hypoglycemia. Thirdly, the muscle clock. The skeletal muscles circadian rhythms, they regulate the insulin sensitivity and the glucose uptake, and the clock disruption leads to insulin resistance. And lastly, the lifestyle impact. So high fat diet and irregular feeding disrupt the circadian coordination, while exercise rewires the temporal metabolic patterns. So these are the various important circadian clock of the metabolic organs. So next, what happens in the pathophysiology of various metabolic disorders. First is the homeostatic balance, in which disruption of the intrinsic energy, glucose and lipid homeostatic mechanisms, they represents the fundamental pathophysiological basis of metabolic disorders, including obesity and type 2 diabetes. Secondly, the communication breakdown, the miscommunication between the gut, brain, and the adipose tissue, and degradation of the input signaling pathways. And lastly, the maladaptive response. Under these pathological circumstances, the brain responds inappropriately by promoting increased energy intake and enhanced energy production. So what are the clinical implications? So from bariatric surgery to pharmacology. So bariatric surgery, we all know, it alters the gut-brain signaling pathways. GLP-1 agonist mimics the natural gut hormones sensitivity to reduce the appetite and improves the insulin sensitivity. And precision therapies understand the gut-brain adipose pathways, which opens revolutionary avenues. So we all know the therapeutic strategies and the future directions. So what happens, the gut-brain adjustments, I'm not going to the things. So understand the gut-brain crosstalk. So the therapeutic targets for treating the metabolic diseases. So the gut-brain axis represents a sophisticated bidirectional communication network that governs the energy homeostasis through multiple integrated pathways. So lastly, harnessing the gut adipose brain axis. So for metabolic health, complex vital communication has been the vital for maintaining the energy balance and optimal metabolic health throughout the life. Second, the therapeutic hope. So targeting these sophisticated pathways offers unprecedented hope against the growing obesity and diabetes pandemics. Lastly, the integrative future. So future research and therapies must embrace this integrated metabolic network approach to restore the physiological harmony and achieve fasting health outcomes through precision medicine strategies. So conclude, towards precision medicine for metabolic disorders, so complex homeostasis, multifactorial disease etiology, and a holistic control system and precision medicine future. So I just conclude saying that the symphony of metabolic communication, the gut, fat, and brain, they do not act in isolation. Their metabolic dialogue orchestrates the harmony of life's energy balance. So understanding this symphony is key to conquer the metabolic disease. So a happy gut, which is the metabolic conductor, and a good brain, the master regulator, and lastly, the energy reservoir, the various tissues. So this intrinsic metabolic communication network holds the key to understanding and treating the complex landscape of metabolic disorders. Thank you all for patient hearing.
Thank you, Dr. Balaji, for making us understand a complex communication in a very simple way. We now move over to the third topic. Rather, it's a discussion, case discussion on young onset diabetes by Dr. R.P. Rajesh, a very good friend of mine and very enthusiastic on stage. He'll keep us captured to the science of the management of the young diabetic. Over to you,
Thank
Dr.
you,
Rajesh.
Sir. Respected chairperson, senior clinicians, and my dear friends, a very good evening to all of you. I'm going to discuss with you about diabetes in the young, and before I could start, I want to profusely thank the organizers of DAISICON2025 for giving this wonderful opportunity. And not only that, I just want to thank them for giving this particular topic. Because nowadays, we see a lot of adolescent age group people attending our clinic, a lot of school-going children, school-going girls and boys coming to us with metabolic abnormalities. So this is, in fact, the diabetes in the young has almost become a reality, not a rarity anymore. So when you see anybody less than 35 years coming to our clinic with metabolic abnormality, it is easy to diagnose diabetes in them. But what is very complex is that how are we going to classify this? How are you going to classify into what type of diabetes it is? Really type 1 or type 2, or whether it is any LADA or any monogenic form of diabetes? That is actually very, very complex. And most of the times we often see anybody presenting to us with any metabolic abnormality around 30 years, always there is some kind of a diagnostic gray zone. So to guide us through that, let me just start with a real case, a very simple case. And you can see, he's a 29-year-old young male. This happened somewhere in 12th July 2022. So he is actually a middle school teacher in a very remote village in Nagapattinam district and absolutely asymptomatic. If you look into his profile, occasionally he smokes. I mean, he's not a smoker. Occasionally he consumes alcohol. No diabetes in the family. Absolutely no first degree relatives have diabetes in the family. And the issue is This guy actually had some kind of a dental caries, and for that he went to a dentist, and they gave a profile of investigations. Otherwise, if you look into his features, there is no evidence of insulin resistance in him. Again, look into the BMI. BMI is only absolutely normal, less than 23 it is. But when they did an investigation for him, you see, it was 148. He went to these are all done by a dentist. So 148, postprandial is 236, HbA1c was 8.5. For all practical purposes, let us imagine that the other values are all within the normal limits. I'm not going into the discussion of all those parameters. Right. So he was immediately referred to a local diabetologist there in that particular area, and he made a diagnosis of newly detected type 2 diabetic, and he started him on, apart from lifestyle issues, he started this patient on metformin with the glimepiride combination. So the first thing which I want to point here is that whenever you see a patient, very young patient, a lean subject, you can see the BMI is less than 23, and no signs of insulin resistance, and with metabolic abnormality. Always don't think only about type 2 diabetes in this particular patient. But let's see what is going to happen. See, usually there is a conventional thought that when you see an obese patient, then more of insulin resistance will be there, so they usually start on metformin. When you see a lean subject, usually there will be some kind of a secretory defect, so they will be started on some sulfonylurea. So that was the concept. So this practitioner started this patient on both the drugs. Let's see what happened. There was a good response, you can see. There was a good response initially, and again, within a month, there was a good response, and again, next 3 months, the response was maintained. Let's see what happened to the HbA1c. HbA1c dropped from 8.3 to 7.2 with metformin and glimepiride. So this worked out well for this particular patient. So, but the next month, when the patient came for follow-up, you can see this patient was taking the medicines regularly, adhering to the lifestyle, but what happened? All of a sudden, there is an increase in the fasting and the postprandial blood sugar. So this doctor aptly uptitrated. See, we should not hesitate to increase the drug when the blood sugar is not under target. So that's what this practitioner also did. He escalated the dose of glimepiride from 1 mg and made it 2 mg twice daily. So let's see what is the response for this. And again, after increasing here, it is at this point of time the glimepiride dose has increased. You can see within a period of 1 or 1.5 months, the blood sugar actually somewhat came down, but again, in another 1.5 months, so over a period of next 3 months, you can see, again the blood sugar got deteriorated. It went to fasting went high, and again, the postprandial also went up to 283. Let's see what happened to the HbA1c. HbA1c, initially, it was like, it was looking like it was settling, but again, you can see it went up to 7.9. So what should be done here? So at this point of time, again, he did not have inertia. He broke the inertia, the local practitioner, and he again uptitrated the medicine for this particular person. So what happened? A third molecule was introduced. What was this? So this patient was again started on pioglitazone in a dose of 15 milligram once daily. So this was the treatment given to him. And remember, he's a lean subject with no signs of insulin resistance. How many of you accept giving pioglitazone to this patient? Okay, but at least something has to be done. So that was the idea behind this patient was started on this particular drug, and again, let's see what happened. So after starting pioglitazone, you can see the blood sugar did not come down over a period of 3 months, and again, the blood sugar actually jumped up to 8.5, which means did not show any response to all the 3 molecules. So what has to be done next? So again, another molecule was started for this particular patient. Fourth molecule was started for this particular patient, sitagliptin. So what we need to understand is that when a lean subject presenting to us with dysglycemia, not responding to 3 oral drugs, rather than looking into what I have to do it, what I have to uptitrate it, what new molecule I have to introduce it, actually we have to revisit the diagnosis and look into what am I actually dealing with. Is it really a type 2 diabetic subject? So that is what we have to look into it. But again, let's see what happened after starting sitagliptin for this particular patient. Absolutely lost follow-up. Then this person moved to Chennai, presented to our clinic. Again, at that point of time, you can see, again, 6 months later. So this is 1.5 years later. 1.5 years after the diagnosis of diabetes, this patient presented to us, and here you can see he presented with all sorts of classical symptoms of diabetes: tiredness, nocturia, excessive thirst. All these things were there. Huge fasting is too much. 224, postprandial was 357, HbA1c was 10.4, urine acetone was done, which was negative for that particular patient. Again, you can see, look into the BMI, 22.9, same, almost same. And again, waist circumference was measured, again, it was 78. So no central adiposity also for this particular patient. And again, other things are all normal. And one additional history what we could get from this particular patient was that patient's mother as well as some younger sister had hypothyroidism. So this is one thing. So some signs of autoimmunity was there in that particular family. So that's all we could get. So again, this is the current scenario. So at least at this point of time, this is actually too late, but at least at this point of time, we should again revisit the diagnosis. What are we dealing with? 4 molecules have been started within a period of 1.5 years. The HbA1c has never come under target. So this is what we need to understand. So in this scenario, we always have to be very careful. Lean subject, no signs of insulin resistance, no family history of diabetes, dysglycemia in spite of starting 4 drugs. So this is where, how are we going to evaluate them? So always we have to remember this particular alpha beta centric classification. So it simply uses 2 tools. Very simple tool. You do an antibody testing as well as you do a C-peptide. These are 2 tools, and thereby you can differentiate what exactly are we dealing with. So in this context, when you look for autoantibodies, when the autoantibody is actually positive and when the beta cell function is preserved, probably we are dealing with something called as LADA. Again, when the autoimmunity is positive, when the autoantibodies are positive, but when the beta cell function, that is the C-peptide, is very, very low, then probably what we are dealing is a type 1 diabetic. And again, when there is no evidence of autoimmunity, all the autoantibodies have been negative, then probably when there is a preserved C-peptide level, then probably it could be type 2 diabetes, or in case if there is a classical history of 3 generational transmission, then we can suspect probably this patient is having MODY. Or else, if the C-peptide is also low, then again we can say that this patient is having type 2 diabetes, which is more prone for complications. So this is a framework, an alpha-beta framework. With the help of 2 wonderful tools, we can able to classify which type of diabetes is this. So this is what we have to subject this patient into. So what happened was that when a C-peptide was done for this patient, what you can see is this, very, very low. So what do you think this patient should be having? The beta cell reserve is very low at this point of time. And again, when autoantibodies was done for this particular patient, GAD65 was done, and again, you can clearly see that it is 23, 22, anything above 10 is positive, anything less than 5 is negative, so you can see it is well above 10, so 22.3, it clearly tells you there is an evidence of autoimmunity in this particular patient. So what are we dealing with so far now? Is it a type 1 diabetes? So if you go back, see, C-peptide is not there. It is again, remember, C-peptide was done 1.5 years after the diagnosis, not at the time of diagnosis. And again, after beating the beta cell with too much of sulfonylurea, the C-peptide was done. Had the C-peptide been done little earlier, probably at that time some amount of beta cell reserve would have been there. So I think this looks like a classical case of LADA. So this is what we need to understand. So the message is that not all diabetes in young is having type 2 diabetes. Whenever we see a lean subject, an young individual with no family history of diabetes, with no features of insulin resistance, no central adiposity, no acanthosis, no skin tags, no obesity, if it is like that, always we should have a suspicion of that we are dealing with something else other than type 2 diabetes. So that's what we have to think. And again, investigations will again show in which direction we are going. In this way, we have to go for an autoantibody testing as well as we have to look into the C-peptide. In this particular case, you can see autoantibody was positive and C-peptide was very low, which clearly told that this patient is having LADA. Had this C-peptide was been done little earlier, we could have even picked up a classical LADA. So this is what. So from now on, what happens is that the C-peptide is, the beta cell reserve is completely washed away. So probably this is going to behave like a type 1 diabetic. So probably this has to be exclusively managed on the insulin alone. So what we need to understand is that the treatment should match the biology. What exactly the pathophysiology in that particular patient, that has to be matched rather than chasing the blood glucose level. So timely diagnosis can prevent years of mismanagement. So this is one case. With this, let me move on to another case, another real case. Here you have an young individual 18-year-old girl presenting somewhere again way back in the August 2022. She was actually a college student from Pudukkottai district, and again at that point of time she presented to a local physician there with classical symptoms of diabetes, excessive thirst, nocturia, tiredness, all these things were there. And what happened was that if you look into the family history, father had diabetes, that particular patient. I think again, look into the BMI. Again, this is a confusing picture. If this patient is obese, probably we can think in types of any type 2 diabetes, but this is again a lean subject. You can see the BMI is only 22.1. Again, there is no evidence of insulin resistance, no acanthosis, no skin tags or no central adiposity. All these things are there, not there. And again, if you look into the blood investigation of this particular patient, you can see fasting blood sugar was 367, postprandial was 487, HbA1c was 14.1. In spite of all these high value, urine acetone was actually negative, and again, a C-peptide was done for this particular patient at that point of time, which clearly tells you it is a very low value, which is a low value. Anything less than 0.8 is low value. So this is the C-peptide, fasting C-peptide is very low, and with this, they came into conclusion that probably this is not a case of type 2 diabetes, and again, to understand, she was diagnosed as type 1 diabetes, but to prove a diagnosis of type 1 diabetes, what we have to do is that we have to prove autoimmunity there. We have to look into the evidence of autoimmunity there, and again, they did a GAD65 antibody that actually was negative, but again, we need to understand that 70 to 80% of the cases GAD65 antibody will be positive, but if you want to really pick up a case of type 1 diabetic, you have to go for an autoantibody panel, which should include IAA, also zinc transport rate. All these things has to be done, but this girl was not an affordable girl, so probably for that reason they just assumed it as a type 1 diabetic and started her on conventional premix insulin. And I told you she is a college-going girl, so she was not able to be started on basal bolus because in the afternoon dose was not possible at the college time. So they started her on twice daily premix insulin, conventional premix insulin. How many of you are convinced with this? How many of you are convinced that this is a case of type 1 diabetes? So let's see what happened. So she was started on twice daily premix insulin. So what happened? So gradually the blood sugar, based on the blood sugar, the insulin dose was increased to 20 units in the morning and 25 units in the night. So I will just show you the value. Initially there was a very good improvement. You can see 367, it dropped down. It became almost normal glycemia. Over the first month and second month, you can see very good control. But what happened was that she started developing repeated hypoglycemia. So what ultimately, she was forced to stop that insulin. Once she stops that insulin, she feels better. But again, what happens is that when she checks the blood sugar, it goes for severe hyperglycemia. Then again, she gets scared. Again, she restarts insulin, again goes into hypoglycemia. So this cycle, this vicious cycle of repeatedly stopping that insulin, restarting it, going for hyper and hypo and hypo and hyper repeatedly happened. She became annoyed. She was very happy when she stopped insulin, but everybody infested the thought that insulin is required for her survival. So for that, whenever she is not taking insulin, she always thinks that she is doing something really bad for her. So this kept on annoying her. She developed depression. And again, she dropped out from her college. She was not able to go to the college anymore. What happened? She joined some textile showroom as a salesperson. She joined there, quit the college, went into a thing. And again, the thought that she's not insulin, she's doing something harm for her, again made her too much of guilt. She started developing suicidal tendencies. And she also had one failure attempt of suicide. So all these things were there. And again, she was again subjected to counseling for that. And again, what happened was that after a period of time, maybe after a period of 10 months, this patient again came to Chennai. And at that point of time, you can see on and off insulin, some touch of insulin, on and off she was there. So with that, her HbA1c actually, at that point of presentation to us, you can see the HbA1c was actually somewhere around 9.2. And the fasting was somewhere around 209 and postprandial was 293, still very high. But again, urine ketones was done at that point of time, which was also negative for this particular patient. So what are we dealing with in this particular patient? So we start this patient was started on insulin, getting into hypo, and again, once he stopped going for hyperglycemia. So this is this was something annoyed her. So how are we going to approach this particular patient? We have to evaluate. Unless we evaluate this patient and start her some medicines, nothing is going to work out for her. So what was done? She was reassured and said that because you had a very high dose of insulin, because you did not titrate it properly, that's the reason you went into hypoglycemia. So she had already a few stocks of the conventional premix insulin with her. So it was reassured. Instead of taking 45 units per day, I'm going to give you less than 50% of your original dose. So just start with 10 units in the day. And she was educated properly regarding the usage of glucometer, and as well as she was educated on regarding how to prevent her hypoglycemia. And again, from 10 it was titrated to 12 in the morning and 12 and 14 in the night. So what happened after that? The blood sugar again from 206, from this value, within a period of 15 days it dropped down, and again it was maintained. So at this point of time, further evaluation was done for this particular patient. You can see a C-peptide value was done. What happened to the C-peptide at this point of time? Where it was low at that point of diagnosis time, you can see the C-peptide, it is well preserved. Now the fasting C-peptide is 1.15 and the postprandial C-peptide is again 3.62. So again, so what do we infer from this? Again, the autoantibody testing was already done, GAD65 was already done, so it's not affordable, so we were not able to, again, there is no point in repeating it. You have a C-peptide, you have an insulin reserve, so what is the point in looking into the autoantibody provided GAD65 is negative? GAD65 will be positive in up to 90% of the LADA cases. So you want to roll out LADA, you want to diagnose LADA, you can go for one antibody which is GAD65. But you want to find out whether it is type 1 diabetes or not, there you have to go for a panel of antibodies. So GAD65 is well enough to rule out a LADA, so that was actually negative in that particular patient. So what happened? So now, what could have been the reason? So now what is the case now? Is it still type 1 diabetes? Probably it could be monogenic diabetes, but family history of 3 generational transmission was not there. But again, that doesn't rule out a case of MODY, because they are all living in remote areas. Most of the MODY will be having mild hyperglycemia. So what happens is that it will go unnoticed in the grandfathers as well as in the father. Here the father had diabetes, but again, could it be MODY having a very high presentation but without any organ complications? You have, recently we were all discussing about type 5 MODY in so many forums. Dr. S.S. Lakshmanan sir picked up one case of type 5 MODY. There, that was very, very high blood sugar levels and going for other renal complications. But here, other complications are not there. So still could it be MODY? Yeah, we can't rule out MODY here. But again, definitely this is not a case of type 1 diabetes. Beta cell reserve is there. So what happened was that C-peptide was done at a wrong timing. C-peptide was done in this patient when the blood sugar was too very high. HbA1c was 14.1, fasting itself was 347. At that point of time, there is glucotoxicity. There will be your beta cell function will not be just like an acute kidney injury. There will be stunning of the beta cell, so your insulin production will not be there at that point of time when you are going to do a C-peptide. It is going to mislead us. So doing a C-peptide is very important, but again, knowing when to do it, when not to do it is more important. So that is what was mistake. So actually what happened to this patient? So insulin was slowly tapered with the introduction of oral drugs. Then slowly insulin was tapered and stopped. And this particular patient now just once daily, sitagliptin with metformin, just once daily, 100/1000, once daily, she was able to maintain her blood sugar level. She even rejoined the college. She stopped working and she even rejoined the college. And again, you can see with oral drugs alone, you can see the blood sugar was maintained throughout, and you can see from the HbA1c dropped from 9.2 further again, absolutely normal. So last follow-up was somewhere around January still to see this patient. So this is the message. So what we need to understand is that we told about 2 tools. Yes, we need to go for, whenever there is a diagnostic dilemma, we have to go for autoantibody testing and we have to go for C-peptide. But again, remember the timing of the investigation, at what time we have to do it. So the learning issue from this case is that at diagnosis, glucotoxicity can be there, and that can suppress the C-peptide levels. So C-peptide levels should always be done after achieving near normal glycemia. Or in case, if you have done it, there is nothing, you always have to repeat it after achieving a near normal. Initially, when the patient was done C-peptide, again we have to repeat it after normal glycemia has been achieved. So, you know, the doing antibodies tell us why there is a beta cell failure, whether there is autoimmunity or not. And doing a C-peptide will tell us how much insulin reserve is left. When you do these two investigations at appropriate timing, what will happen? We can prevent many years of misclassification and mismanagement. So with this I end my talk. The topic is open for discussion. Yeah. It's also? Yes. Yeah. See, suppose if the same patient has autoimmunity positivity, GAD65 was positive, probably we all know that it could be a LADA. But here, autoimmunity evidence is not there. Probably what we are dealing with could be a type 2 diabetic, but not a frank type 2 diabetic, something like a severe insulin deficient type 2 diabetes. Severe insulin deficient, SIDD we call it, so beta centric classification. Probably it should be a case of SIDD, where again the beta cell reserve is very, very low, and again probably they also may require insulin very shortly.
Later.
So could be SIDD, could be a possibility.
So what will be chronic malnutrition leading to this?
There is no evidence of malnutrition, madam. She is a normal BMI. BMI is normal. BMI less than 23 is normal. We are not supposed to have any BMI of more than 23. So this is not.
Socioeconomic status.
Yeah, that doesn't mean that there should be malnutrition there. The socioeconomic status was poor, she cannot afford for higher investigations. Repeating an antibody panel which can cost her 10,000 rupees, that may not be possible for her. But to take a proper nutrition, to that extent to develop malnutrition, she is not starving. So probably this could be a case of, Dr. Lakshmi is there, she is about to tell something. Yeah. Yes. Yes, yes. Correct.
Over the period of time, we will learn about the case. We just have to wait for some more time in these cases.
Absolutely. But the only point was why she was so very lean and why she presented with a very high blood sugar. Correct.
Sometimes they may.
Correct. Probably with oral drugs. Correct.
She might have had excess of glucose in some function or other.
Yeah.
Presented at that moment with the typical symptom.
But the HbA1c was 14.1.
Yeah.
We can understand the fasting and postprandial rising to that very high. But HbA1c itself was 14.1.
So once when the glucotoxicity is there, the insulin secretion falls down. And she remained like a type 1 for quite some time. And then
Correct.
once when we break the glucotoxicity, probably she has risen.
Correct.
Anyway, thanks for an excellent
Thank you,
discussion.
sir.
Now we'll move on to the next section. Thank you.